Good evening. My name is Dr. Tanvi, and we are gathered here for the IRIA session, and I welcome you all from the behalf of Medflix. We are gathered here on the behalf of IRIA Kerala, where Dr. Praveen Nirmalan would be talking about the topic Study My Question, How to Choose the Correct Design. Before heading towards the topic, I have some instructions that I would like to talk about. We would highly recommend attending the today's session with the headphones. And if the video gets stuck at any point, you can click on the rejoin button to rejoin the discussion. And if you want to see, if you're not able to see anything on the presentation, you can pinch in to zoom the shared presentation. And you can share your questions or doubts in the comment section below on the right hand side of your panel. And please, you can use a lot of emojis to express your opinions that is there on the lower bottom side of your screen. Giving it over to Dr. Joshi to take it forward.
I
Yes.
One second, Tanvi.
Yeah.
Uh, this is our third dissertation program by Dr. Praveen, and I'm happy because the IRA has taken initiative for teaching the residents, because most of the residents don't know how to write a dissertation. So we are very happy to have Dr. Praveen, and Dr. Joshi is going to chair the session today, who is HOD of Alepura Medical College, which is a government institution and who have got lot of residents there. So, Dr. Joshi, I welcome you to this platform to chair the session and introduce Dr. Praveen. Dr. Joshi, can you unmute? Doc- Yes.
Can you hear?
Yeah, I can
Okay.
better.
Good evening, everybody. Thank you, ma'am. And today, the presenter is Dr. Praveen Nirmal. He is a super specialist in ophthalmology. He's a vitreoretinal surgeon, basically. And after that, he has taken MPH from John Hopkins and shifted his works to research in ophthalmology. After that, in OBG, anesthesia, and finally to radiology. Critical care also was one of his interesting uh, areas, and the focus is more on improving the research methods for clinicians, so that the clinicians and the residents with their help the residents with their thesis, trying to develop a clinician scientist. That is what he's saying. And these clinician scientists, they know the real world problems, who will think and find local solutions for these their local problems. And that has been his aim for the last 15 years or so. um, and on the topic, actually, the thesis methods or research methods are usually neglected in almost all conferences. Now, it is very appreciable that from the side of the IRA office bearers to include this topic for discussion, and this may help to enlighten our PGs to have a direction to do their thesis in a better and interesting manner. Actually, they are doing it just for somebody, just for finishing their course. That's all. This may make them these topic may make them the writing of the thesis interesting. I think so. So I welcome Dr. Nirmalan and all the audience to this scientific session. Over to Dr.
Thank
Nirmal.
thank you, Dr. Joshi, and thank you, Dr. Gomadi, for the introduction. Thank you, Tanvi and team. Uh, this is the third session of the series, 12-module series that we are looking at dissertation guidance. as part of the Kerala IRIA President's Program. And today, in this third session, we will look at how do you design, how do you choose the design for a research question. And we will look at a basic introductory approach to this. The study designs are usually like an ocean. We won't get into the complete ocean, but we will start the process of trying to understand how do we choose a design for a specific question. For those of you who are new here, just a slight recap. We looked at the key elements of the introduction, how to write the introduction chapter of your dissertation in the first session. And in the second session, in the previous session, we looked at the key elements of a good research question, hypothesis, and aims and objectives. In case you have missed those sessions, you can find the recordings of those sessions in the Kerala IRIA Club on Netflix. They'll be up shortly. The first session is up, the second session will be up shortly. What are the learning objectives for this particular session? The basic objective is to understand the basic elements that you can use to choose an appropriate design for your research question. Now, why is that important? Why is a study design important? It's only when we understand the importance of the study design that we would look at ways to choose that appropriately and carefully. Now, every question has got a specific design that is ideal to answer that specific question. And if something is ideal, given that we live in a world of jugaads, there will be an alternate design that's also practical if the ideal design cannot be applied. So there is an ideal design, there is an alternate design. But every question that you ask has got a specific design that will help you get the answer for that particular question in a reliable and valid manner. So the study design determines a path for you to follow to get the answer for your question. And if that is not appropriately chosen, you will end up in going through different bylanes, not on the national highway, but through small bylanes. And then if you're using Google Maps, you will get stuck somewhere. Where there's supposed to be a road, there might be a pond. So this will be like that. So the design is important for you to determine the path to find the answer to your research question. And that affects the validity and reliability of your research. So it's a very important component of any study. And it's a very important component of your dissertation. What specifically, when I say it's important, what is it specifically important for? So it's important in the sense that every design gives you an idea, fair idea of how the study population is identified. The study population can be identified as a section of a population. Maybe in a specific design, it involves selecting people with the disease and compare them with people without the disease. In another design, it involves selecting people who are exposed to a particular factor and looking at what happens to them later on based on the exposure to this factor and comparing that to people who have not been exposed to that factor. Study population can also involve people who have been subjected to one particular intervention and comparing that to people with a different intervention. Each of these blocks of study population fit into a particular design. So if you're looking to study something else and you pick a different study population or a different design, it doesn't work well. It doesn't align well. So the design is important for us to say that this would be the way, this would be the study population that we are looking at, the way we are planning to select the study population that we are looking at. And that comes from the design. The study design is also important in that it then determines the ascertainments and the time of ascertainment of measures, of study measures that are going to be done as part of this study. For example, it can be a single time assessment on a patient for the study. It can be that you will do multiple assessments over a period of time, longitudinal. You will follow up the particular subject and you will have multiple assessments at multiple periods of time. You can't do that. You can't do this multiple assessments in all study designs. You can't do a single one-time assessment as part of all study designs. So the study design is important as it relates to the way that we use the methods to find the answers to our questions as well. Very importantly, the study design has a great role to play in the determination or estimation of sample size. Now, sample size is where we usually end up frowning and whining and feeling sad about everything. But the sample size is important in a research study. And I'll just very briefly tell why it's important. We won't get into a nitty-gritty of that now. We will look at that in a later session. But very briefly, why is the sample size important? Why should we look at it? If we do not have an adequate number of subjects, if we do not have an adequate sample size, we are not able to determine if a lack of difference between groups, a lack of significant difference between groups is actually truly a lack of difference. Or is it that we are seeing a lack of difference because we have not studied enough subjects? So if we study less number of subjects, we cannot be sure that what we are seeing as an insignificant finding is really insignificant. Maybe if we have studied enough number of subjects, it might become significant. So we can't be sure of that. On the other side, if we study more subjects than what is needed, the first thing that we must consider is we are then subjecting an extra number of people to be part of the study when they need not be part of the study. For instance, if we estimate the sample size as 50 and we study 100 people, the extra 50 people actually need not be part of the study, but we are subjecting them to this study. And that is unethical. We would have got the results, valid results with 50 people, but we are subjecting this extra 50 people to a study without any particular reason. They're not going to add anything to the study. It's only trouble for them and trouble for us to try to complete those numbers. The second point is that if we study more than necessary subjects, more than the necessary number of subjects, any small difference can also end up looking significant. So it adds more noise. And you might find that even minor differences then become statistically significant. So both lower sample size and higher sample size are problematic. Lower sample size is more problematic than a larger sample size, but both are problematic. And the study design is the one that helps you estimate the sample size because the formula to estimate the sample size is design specific. And the assumptions that you make for that estimation of the sample size are also design specific to a large extent. So that's another importance. Again, the other importance is that every design can give you a certain set of results. And we'll look at that as we pass through this particular talk. When we talk of results, it can be we want to know the magnitude of a condition. We want to know what is associated with this condition. Maybe we are looking at prognosis. Maybe we are looking at effectiveness of interventions. Maybe you are looking at what causes this particular condition. But for each of these factors, we must apply a specific design. So if we apply a wrong design, we won't be able to comment and reach a conclusion on these factors. For instance, if I want to look at effectiveness, but I designed a study where it's only possible to estimate the magnitude, I'm not going to be able to comment on the effectiveness. Effectively comment on the effectiveness. And so the design becomes important even for us to understand what results can be obtained from a particular design and how can we interpret that. Again, the design is important because of the bias that comes with particular designs. Now, bias is a systematic error. It's an error that occurs in the process of measurement. It's a systematic error. And different designs have got different inbuilt biases that can occur, and you aim to minimize those biases. We won't get into the details of that now. We'll do that in a later session. Several other terms come into play: an observational study, an analytical study, a descriptive study, an experimental study, and we have design specific elements. Now we have all these terms, but let's keep it real for this discussion. As I said in the previous sessions, the learning is going to be more of applying rather than theoretical concepts. So let's keep it real. You are busy clinicians. You have loads of patients. Time is a factor. There is, you don't want to spend too much time trying to break all of this down while you feel that you could possibly use that time to to take care of a patient. So you want something that can be done easily. You want to make sure that it is appropriate yet more easier for you to do. You might be a busy resident, lots of work, and the whole world is dumping on you. Everything is dumped onto you, especially when you're a new resident. And we have all gone through that phase. So, as a clinician, the key aspect is, can I have something I can use in my work to pick a design fast? I'm saying this problem, I feel like I want to study it. What design should I pick? And that's the first step. What design should I pick? So, can I have something that I can use in my work to pick a design fast? And let's try to see if we can do that. So, let's walk through some clinical scenarios. And the first clinical scenario is, I see a patient with an abnormal finding that I have not seen before. This is different from what I have learned and what I expect to see based on my experience and available knowledge and evidence in the literature. It's different, it's a new finding. I want to share this with my peers and my teachers and my friends and my juniors. Of course, to share knowledge, to clarify, to make sure, reassure myself that I'm on the right path, and without saying, of course, to also show them that yes, I am indeed intelligent. You thought I am not intelligent, but I really am intelligent. Watch this. So, can this be a study? So, this comes in the realm of a very basic design, the case report, where we are looking at a single patient, a single image, or image from a single patient, samples from a single patient. We are looking at something new. And it's an observation. We are observing this. We are observing this in this single patient, and it is a new finding. So those are the three key elements of a case report. It's a single person or a set of samples from a single person, images from a single person. There's something new, and it's an observation. What does a case report not give us? It does not repeat something that's already known. So if it's already known, it's not a candidate for a case report or case report design. It is not useful to report on any interventions. It's not accepted to use a case report to report on an intervention unless it's a very, very rare condition and you don't get enough numbers. But ideally, no. Most journals now refuse to accept a case report based on interventions. You really have to justify that the numbers are not there. It's a very rare condition, and hence, and very importantly, the case report does not provide conclusive evidence. It only generates a hypothesis. You're only able to say, in this particular person, I saw this finding, and this is a description of that finding. And I can speculate that this is why that is happening, and I'm generating a hypothesis for further study. I cannot provide any conclusive evidence. And the reason I cannot provide any conclusive evidence is because it's a report from only one patient. And each person differs from the next person. So I cannot generalize, and therefore I cannot provide a conclusive evidence. There's no formal statistical testing or anything that happens in the case report. A case report is not part of a dissertation, but the case report has value, and I'll discuss that value a little later. The clinical scenario 2, it's the same scenario where you're finding something abnormal, but it's in a series of patients. Different from what you learn, different from what you expect to see, different from what is reported in the literature, which naturally assumes that you are keeping in track of the literature and you are reading and reviewing the literature. You want to share this. Now, this becomes part of a case series. So it's a series, it's a report, single patient, a series of patients, a case series. Again, something new, it's an observation. The question that comes is, how large is a series? If I take 30 patients, is that a series or is that an original research study? there is nothing set in stone. There's nothing set in stone that a series is so many numbers, and after that it shifts to an original research. A practical way to look at it would be, let's estimate a sample size and see for that particular problem. And if we have less numbers than that estimated sample size, it can become a series. If we are meeting that sample size, estimated sample size, it can shift to an original research study. Now, the case series is like the report. It does not repeat something that's already known. It does not report on interventions. It does not provide evidence, conclusive evidence. It cannot tell you about the effectiveness of interventions. Again, the caveat there is that if it is a very rare condition, then you can use the case series to report on interventions. With this, by stating the limitation that this is a series, we are not able to provide conclusive evidence, but we are generating this hypothesis that this particular intervention is effective. So that is the case report and the case series. Now, are they useful? When you're setting out to do your study, when you're setting out to do your dissertation, actually it starts from what you see in a single patient, most often. Or ideally, it should start from what you see in a patient, and that is your case report. And then you look over, see a few more patients of that, and then you're looking at your case series, and then you're thinking, okay, I'm seeing this. Is this a study that, is this something that I should pursue? This is a question that I need to answer. So it starts with a single patient, it moves through a few patients. So the case report and the case series are important for you as you're trying to develop your question, whether you're a clinician or you're a resident. Your questions come from your patients, your samples, the images that you see. They should come from that idea. And we talked that in the previous session. They should come from that idea. And the case report is the first step. The case series, even if you're not publishing it, the case series is the next step. And then you're saying, yes, there is something in this that I must look at. And now you're thinking of taking it up further as a original research study. No, in terms of publication, the case report and the case series are considered low down on the evidence pyramid. But everything on that pyramid, from your observational study designs to your systematic reviews, your meta-analysis, your clinical trials, everything on that pyramid actually builds on the case report and the case series. And the key point is, if the foundation is not strong, the pyramid cannot be strong. If the foundation that is setting out the hypothesis is not strong, if the initial observation of the case is not strong, then everything after that is not going to be strong. It cannot be strong. Now, the case report and the case series are something that every clinician who sees a patient, everyone who sees an image, everyone who deals with a sample can actually engage in. There comes a time when you see something new. There comes a time when you see something new in a series of people. And that is something that you can then take to yourself. This is something that can be done by every clinician. There is no problem whether you are in a remote area, you are in a primary setting, you are in the most advanced setting, whichever setting you are, wherever you are, the case report and the case series directly link to your clinical observation. So this is something that everyone can learn, and it's a skill that must be learned. The description of the case is a skill that must be learned by every resident and young clinician. Holds you in good stead. So let's move to the next scenario, the third scenario. Now here, the question is that I'm seeing a lot of patients of condition X in my practice. I'm having a OPD, I'm having a diagnostic lab maybe, I'm having an imaging center maybe, I'm seeing a lot of condition X in my practice. I want to know the magnitude of condition X. And the reason I want to know the magnitude of condition X can be because for reasons of providing healthcare. It also has practical applications in the sense that if I know the magnitude, I'm able to plan my workload better. It tells me whether I need to invest more in terms of personnel, in terms of infrastructure, in terms of resources. So in a sense, I'm trying to show you that research in healthcare is not related only to a disease. It's also related to the daily routine planning that goes around the running of your setup, your clinical setup, your public health setup, your diagnostic setup, your laboratory setup. If you know that you are seeing a lot of condition X, you're able to then plan what is needed to identify condition X. Maybe it's you need more people. Maybe that condition X needs a person to be taken to multiple places for further investigations, an MRI, a blood test, a clinical assessment, multiple places, maybe. So then you need personnel to take them around. You need a teamwork. You need to invest more on personnel. Maybe you need to invest more on infrastructure. Maybe you need to invest more on resources. It also tells you, well, if I'm seeing more of this, do I need to upskill myself? So it takes you to the realm of, do I need to improve education, my education skills, my training decisions? Do I need to attend a CME? Do I need to attend a workshop? All those come into play. These are things that we do routine. And expansion decisions. Do I need to open more branches in certain other areas because there are pockets of this magnitude in different areas? So all this come into the picture. Now, the key is, what do I really want to know? I want to know how many people have the condition. And when I say how many people have the condition, it's not just the people who had the condition in the past, even the new cases. So I'm looking at prevalence, old plus new cases. How many people have it? When I see 100 people, how many people have hypertension? How many people have type 2 diabetes? How many people have tuberculosis? How many pregnant women have preeclampsia? Magnitude. In which groups is this condition more prevalent? That gives me the associations. And why is that important for me? So that I can identify the high risk groups and say, okay, these are the groups I need to focus more on for these particular conditions. And then streamline my investigation, streamline my management processes, pathways along that line. Now, how do you study this in a clinical setting, in a busy clinical setting? So you can study a section of the population in a defined location, in a defined time period. And you want to just know this section of the population in this place, in this time period, how many people have this condition. So it's a one-time assessment of each person. A single time assessment against the criteria that's being used to define disease. One-time assessment. And that's the key element of this particular design. It's a single time assessment for each subject. What we are not looking to study is what happens over a period of time. We don't want to know that now. We want to just know what's the magnitude and what's the association. So we are looking at a specified period of time, specified location, specified population, and a one-time assessment. We are also not looking to see what causes this condition. We're just looking at the magnitude. How many people have this? And which groups are more likely to have this? So what is associated with this condition? And that is a cross-sectional design. Now the cross-sectional design tells in its name itself, it is across a section of people, across a location, across time, and it's a one-time assessment. So you can understand the magnitude of the problem, you can understand which are the high-risk subgroups, and equally important, you can understand which test will help me identify the condition better. So if I want to compare two tests, if I want to compare two imaging modalities, if I want to compare two tests, diagnostic tests, this is the design, a cross-sectional design. I take people with the disease, without the disease. I apply test A, I apply test B, one-time assessment. I look to see how many have the disease, how many do not have the disease in the two groups. And then I reach a conclusion that test A is better than test B, or test B is better than test A, or both are nearly similar. But the design is a cross-sectional design because it's a one-time assessment. The ideal design or the most often used design is a cross-sectional design. If we have to repeat the test multiple times, then the design changes. But otherwise, one-time assessment, cross-sectional design. That's a key point to remember in a cross-sectional design. It's a single time assessment for each subject. When I say time, it's not in terms of AM or PM but that for each subject in the study, the assessment, diagnostic assessments are done once. So the cross-sectional design, when will I use it? To understand prevalence, when I want to look at associations, when I want to test for diagnostic effectiveness. When is it not useful? If I want to compare interventions, no cross-sectional design. If I am looking at longitudinal follow-up, repeat assessments, no cross-sectional design. If I am trying to find out the incidence of a disease, no, not ideal. The only place where it's ideal is when the condition is very acute and the duration of disease is very short. Let's say it's like a food poisoning. It's here today, it goes off tomorrow. In that case, because the duration of disease is very short, the prevalence will be equal to the incidence. So in that case, you can use a cross-sectional design. But otherwise, to no incidence, you cannot use a cross-sectional design. Why is that so? Because we are doing a single time assessment at that point of time. We are not doing a repeat assessment. So people, what is incidence? New cases. So we are looking at people who don't have the disease on that one time assessment, and then we follow them up to see who gets the disease. That's not possible in a cross-sectional design. That's not a cross-sectional design. So that goes out of the picture. Can we say that factor X causes disease Y? No, we can't. Because again, we are looking at a one-time assessment. At that one-time assessment, all that I can say is that when I found out that this person had this disease, they had factor X. I cannot say that factor X came before the disease or the disease came before factors. All I know is that at that particular time, both of them are there and there is an association. That's all that I can tell. So that's the limitation of a cross-sectional design. So if you want to look at causality, we cannot use this. So it's important to know. If your question is looking at comparing interventions, rule out a cross-sectional design. If it's looking at follow-up, repeat assessments, longitudinal data, no cross-sectional design. If it's looking at causality, no cross-sectional design. If your question says, I want to understand the prevalence, think of a cross-sectional design. I want to look at an association, think of a cross-sectional design. I want to look at diagnostic effectiveness of tests, think of a cross-sectional design. Where can we do it? We can do it in a hospital, we can do it in a community, in a population, in a lab, diagnostic facility, screening camps, outreach, literally anywhere. And it's a favorite dessert for the dissertations. One of the most common designs that are used for a dissertation is a cross-sectional design, and that's a very pragmatic choice. It's a pragmatic choice because it's a single time assessment. You don't have the worry of not running behind follow-ups, not getting follow-ups, missing data. All those things don't come into picture. If you devote your time at that single point, that one-time assessment, you get enough data and you can run a clean cross-sectional study design. But it also limits the type of questions that you're then able to address as part of your dissertation. So that's something that you have to keep in mind. But it's among the most favorite designs for a dissertation because it's something that can be completed during the duration of the dissertation. Let's look at the fourth clinical scenario. I see a lot of patients with clinical symptoms and signs suggestive of fatty liver. I would like to have a more quantifiable method to assess fatty liver. I'm using clinical scores. I'm using biochemical markers. It's not helping me. Biochemical markers, turnaround time is high. Not all of them are able to do it. Clinical scores are not reliable. I want something more quantifiable so that I can monitor progress with the therapeutic advice that I provide. My workplace has got an ultrasound unit, but they're overworked as I do the USGs for all the cases in the hospital. So what I want to know is whether I can choose high-risk groups to send for an ultrasound rather than sending everyone for an ultrasound. Can I choose a certain subgroup of these people that I clinically suspect to have fatty liver and send them for an ultrasound exam? I want to know what clinical factors are associated with a positive ultrasound exam so that I can do a targeted referral of high-risk patients. So how can I study this? We can do a prospective study. We can say, okay, let me do that prospectively, and I send all patients for UST, a certain number of patients for UST, and I study factors that are associated with UST positivity for fatty liver. The problems, there are problems related to time. I need to run it prospectively. I have to send everyone there. There's a time factor. It might take months, it might take a year, depending on the caseload. So it's a problem sometimes. There is an element of cost. Who pays for all of this? Do I make the patient pay? Does the department pay for this? Where do I get the money for this? Ultrasounds, who pays for it? Do patients agree with it? Will they say, oh, you're just sending me there so that you can make some money on the side? All those kind of questions come into the picture. Equally important, there is a work overload that comes in, both for the sonologist as well as for the referring clinician. The sonologist has to do a lot more now ultrasounds. The referring clinician has to look through a lot more reports, most of which may or may not be normal. So there is an increased workload. So let's be pragmatic and we say we are doing ultrasound for fatty liver already. We have a pool of patients who have had ultrasound for a fatty liver. Why don't we dive into that pool and then see what's happening there? So how do we dive into that pool? We say, okay, I'll pick people who have fatty liver on ultrasound, and that's my cases. So what's happening here? The outcome has already occurred. The outcome is sonographically identifiable fatty liver. That's occurred. That's your case. I then look at who does not have fatty liver on ultrasound, and I call them as my controls. So where the outcome has occurred already, that's my case. And the key point here is, the key phrase here is outcome has already occurred. And that's my start point for this step. I now go back into records and say, okay, among the people who are my cases, what all clinical factors are present? Among the people who I have identified as controls, what are the clinical factors that are present? And I look at an association, which is more in this particular group compared to that particular group, or less in this particular group compared to the other group. And I'm looking at an association. The advantage is that I don't have to study all patients. I can choose a specific number of cases and controls for this, and that's an advantage over a cross-sectional study. In a cross-sectional study, I will choose a cross-section of the population. Maybe there are 20 cases. Let's say I've chosen 100 people. Maybe there are 20 cases, and the remaining 80 are normal controls. I will end up doing 80 ultrasounds on normal people. If I do a case control design, again, I'm just putting out numbers there. I might end up doing 20 cases, an equal number of controls. So 20, 20. Overall 40 ultrasounds as opposed to having to do 100 ultrasounds. So that there is an advantage there. For the same validity of results, there's an advantage there. There are problems with this particular design, this is the case control design, and one of the major problems is that choosing the control is not easy. It's easy to tell that we choose a person without XXX, without a disease, or without this, without that. In practice, it's a very, very difficult process to choose an appropriate control, and it leads to a lot of problems. So the case control design sounds very simple. I identify cases, people without the disease controls, what's there? When you start doing it, it's I get the cases, but who are the controls? Where are my controls? And becomes a real problem there. And becomes problem for several reasons, including the progression of disease. Are they truly without the disease at that particular problem? Is it subclinical? All those things come into the picture. So where can it be done? Where can we do a case control study? You need a healthcare setting with good documentation to do it. You need a healthcare setting with good documentation because you're going back into the case records and you're going to look at that case records to see what's been done and what are the clinical factors. Infrastructure, diagnostic definitions, criteria for identification, assessments, all those things come into the picture. You need good documentation. So when can you use a case control design? Outcome has occurred. That's a start point. Think of a case control design if you are looking for an association. What are the risk factors for this particular outcome? Think of a case control design. If you are looking to say that this risk factor causes this outcome, no. So where can you not use a case control design? If you're looking for causation, no. because the outcome has occurred and you don't know at that particular point. All that you know is that this risk factor is associated with that outcome. You don't know which came first in the case control design, so you can't talk about causation. If you're looking for magnitude, if you also want to report the prevalence or the incidence, you can't, because you are choosing a set number of cases and control. So you can't really tell the incidence or prevalence in the population. And this is an error that keeps coming in dissertations, where in a case control design, you will have the statement that the prevalence of the condition or the incidence of the condition is X%. Not correct. You can't do that in a case control design. Can you report on interventions? No. Why? Because it's retrospective. You're going back into records. Interventions will be unstandardized. Who is getting allocated to what intervention is not controlled, is not standardized. So it's a problem. You don't use it for interventions. Longitudinal data, you can't really do it because you don't know whether the exposure, whether the risk started first, risk factor came first, or the disease came first. So longitudinal data, no. Let's look at the fifth clinical scenario. So we have looked at the case report, we have looked at the case series, we have looked at the cross-sectional design, we have looked at a case control design. The basic elements, only the key important elements I'm telling out here. The fifth clinical scenario is something that we see quite often now. I see a child whose parents bring him saying that he has disturbed sleep and rubs his eyes and blinks more in daytime. They tell me this has started in the past couple of months after online classes started. They say he's almost always on a digital device, schoolwork, homework, no social interaction. I talk to my friends using the device for relaxation, watching movies, playing games, all those things. Your life is now embedded in a digital device. Parents advise him to reduce screen time, and they brought him. Disturbed sleep, he keeps on blinking, rubbing his eyes. And the child asks me, what happens if I watch the screen for long? Why are all of you telling me to reduce my screen time? What happens if I watch the screen for long? So, in a sense, the child is asking me, what are the multiple outcomes that can occur if I watch the screen for a long time? Now, you can apply that conceptually to any question, any problem that you have. If I am exposed to asbestos, what happens? What are the multiple outcomes that can happen? If I am exposed to tobacco, what are the multiple outcomes that can happen? So what are we looking for? We are looking for a single exposure causing multiple outcomes. And the exposure occurs before the outcome. So at the time of starting the study, all that we have is that this particular person is exposed to this factor. The disease has not occurred. And we compare exposure with non-exposure. We are looking again at an association. Now in this case, we are following up longitudinally. We can say that exposure occurred first, disease occurred later, and the exposure causes the disease. And we can look at multiple outcomes that can occur. If you're looking at tobacco, maybe we can say there is lung cancer, maybe we can say there is increased gastric acidity, maybe we can say there is something else, maybe we can say there is sleeplessness, maybe we can say that there is oral cavity, oral problems, all those kind of things we can say. So multiple outcomes. Equally important, this is the design where we can say at the beginning of the study, the person did not have the disease and later developed the disease. So we can really look at incidence. So we're looking at two key points here. One is causation, incidence, and association, of course. So when can we do a cohort design? If you're looking at multiple outcomes from exposure, tick cohort design. If you're looking to report on incidence of outcomes or incidence of disease, tick cohort design. If you're looking to state conclusively that exposure to this factor causes these diseases, it's a cohort design. Choose a cohort design. You're looking at longitudinal data, choose a cohort design. If you're going to report on prevalence, no. The cohort design does not help you. If you're looking at interventions, Again, the cohort design is not the first choice. If you are not able to do a clinical trial, then you can look at a cohort design as an alternate design. But it has its limitations. So these are the places where you can use a cohort design. You can use it in a healthcare setting, you can use it in a community or population-based setting. The sixth clinical scenario is, I have been prescribing medicine X for disease Y. I hear a talk by an expert that says medicine B is new and better medication, or it can be any other intervention. Now, should I shift to medicine B? How do I decide that? Can I study that on my patients? Do a small study on my patients and see what's happening? Then how do I design that? And this is something that we see more and more coming in. Diagnostic effectiveness of tests is something that we see coming in more often as technology advances, as interventions advances, medications advances. This is also a very commonly recurring scenario in clinical practice at whatever level you are. So what design can we do? What we want to check is whether medicine B, the experimental medicine, works better, or the effectiveness of medicine B compared to medicine X, which is a current standard for disease Y, which is a condition of interest. So that's what we want to do. And for any interventional study, the gold standard is the clinical trial. The clinical trial has got multiple ways to, multiple pathways, multiple ways to do a clinical trial, multiple types of clinical trials. But we'll do that, we'll do a separate session on clinical trials alone. Multiple ways to do a clinical trial. But that is the gold standard for any interventional study. If you are looking at reporting an intervention, trying to convince someone that this intervention is better than that intervention, you must do a clinical trial. If you are not able to do a clinical trial, then your next alternate best design is a cohort study, but it's not as good as doing a clinical trial. Now, maybe you're just taking a particular intervention on all subjects. In that case, you can still do a pre-intervention compared to post-intervention, post-intervention compared to pre-intervention. An interventional study design, pre-post-interventional study design, where all subjects get the same intervention. So that's also possible. But for interventional studies, clinical trial is the gold standard. And most journals now don't accept if you don't do a clinical trial for that. You'd have to spend quite some time trying to convince the reviewers why you did not do a clinical trial. Most journals of a good standard. So if the key points here to note are, if your question is bringing in that you're going to compare an intervention, you can't think of anything much other than a clinical trial. If you're looking at longitudinal data, yes, you can use a clinical trial. Longitudinal data as part of an intervention, after the intervention. Causality, yes, you can look at causality in terms of this intervention causes these outcomes. Incidence of outcomes, yes, you get it because this particular intervention causes these outcomes, and these are new outcomes, and hence I can get the incidence of outcomes. Can I report on the prevalence of the condition? No, I can't really do that using a clinical trial because I am choosing a section of the population, selecting a section of the population for inclusion in the clinical trial. So I can't really generalize that number that I get to the general population. Y is a better intervention than A. Straight away, you get into a problem because you can't do both using a single design. So you need to then you understand that, well, now it's going to end up in a problem through the process of doing the study, through the results, through the analysis, through the interpretation. And you straight away sort of open the doors to the ICU for your particular dissertation. So be careful about that. Where can you do a clinical trial? Well, you can do it in a community setting. Population-based trials have been done. Large population-based trials have been done. Vitamin A studies are some examples for that. In a healthcare setting, any healthcare setting, a clinical trial can be done. It can be done even in an individual practice. It can be done in any clinical setting. So having looked at some of the common designs and just the key elements or the key parts of the designs, let's look at what are the common errors that are coming from a dissertation perspective, or even from the perspective of writing these up as a paper. Just a few common errors. We see things like I did a prospective study. Now, prospective is not a study design. We need to be more specific. Prospective is an element of time. It says I started now and I went into the future with that. Retrospective is also not a study design. Now, the cross-sectional study, as I said, the key element is it's a one assessment at one point of time. So it's neither retrospective nor prospective. We often find in the dissertation, I did a retrospective cross-sectional study. You cannot do a retrospective cross-sectional study. I did a prospective cross-sectional study. You cannot do a prospective cross-sectional. A cross-sectional study means you are looking at a section of the population at this section of time. There's nothing retrospective there. There's nothing prospective there. It's at this particular section of time. The other thing that comes is I did an observational study, or I did an analytical study. I did an experimental study. Very broad terms, very vague terms. You need to make it more specific. So when you're writing your dissertation, you have to specify I did a cross-sectional design, I did a case control design, I did a cohort design, I did a clinical trial. And you must be aware, very keenly aware of the fact that the design comes from your question. So the first thing that the examiner, the reviewer will do when they're looking at the design is to look at your question and say, well, is this the design that can help you answer that question? And if that is not the design that can help you answer your question, you are in dire straits from that point on. Because from that point on, then everything becomes a problem. So you have to be very careful of what you choose as your study design. After we choose that, then we can look at the specific elements that go into the build of each particular design, and that we will do in later sessions. But for now, what you need to know is, if these are the elements of my question, this must be the design that I must think of as my first choice. The other error that comes, which is actually I would say in many instances a use of a trick of phrase, where we say that I studied a cohort of subjects. And then the implication is that I did a cohort study design. But the truth is, cohort just means a group of people. It's very different from a cohort study design. So if you say, I studied a cohort of people, it does not mean necessarily that a cohort study design has been used. So be very careful of the use of that term also. Now, the most important point from a clinician perspective, from a dissertation perspective, is that specific designs come from specific questions. If your question is not clean, not specific, not focused, does not have the key elements, is not a single question, you will have a great deal of difficulty trying to find the most appropriate design for your question. And that will translate into difficulty in collecting the measures that are necessary for you to answer your question, and doing the analysis, and then interpreting the results of that analysis. So it leads to problems all through. In the previous session, we looked at how the hypothesis and question is a very important component. Aims and objectives are an important component. The design is equally important and builds from there. And if that build is not appropriate, if the build is not aligned, if that build is not perfect, it creates problems throughout later. And so you have to be very careful. Write, rewrite, dissect, reflect, tease out your question till you get absolute clarity on what you're aiming for, and then pick the design appropriate. Now, if you're finding that you're unable to pick a design, check if you have to split your question, and then if you have to split your question, which is the most important question, which is your primary question, and then create the design for that. It's not like taking a thali, a Bahubali thali. There are multiple things, and you can pick and choose and eat this, and it's not like that. Here you're looking for just a plain, simple idli sambar. Nothing else is there. Idli sambar. A clean pathway. That's all. You're not looking at anything else coming into the picture. So you have to make it so specific, so focused for you to get a very clean design. Now, before I conclude, mixed designs are possible. The newer techniques, newer designs coming in, you have a cross-sectional cohort design, we have got nested case control designs, we can do a prospective case control design. All of these are possible. We look at that in later sessions, but the basic elements, the first pick choice, be careful of that. So to end with, let me give you some espresso shots just for the role. One patient, new finding, it's a case report. More than one patient, but fewer numbers than a required sample size, new finding, it's a case series. Which diagnostic test works better compared to another diagnostic test? Cross-sectional design. What is the prevalence? Cross-sectional design. An association, one-time assessment of the measures, a cross-sectional design. Outcome has occurred. I'm looking to see what risk factors exist for that particular outcome, or what risk factors are there associated with that particular outcome. A case control design. My question says there is an exposure to a factor, and I'm looking at multiple outcomes after that. Cohort design. I'm looking to see if factor X causes disease Y. Cohort design. Causality, cohort design. I'm looking to say what is the incidence of new cases, cohort design. I'm looking to compare interventions in my question, clinical trial. So this is the very simple navigation tool to pick the initial design. So in every session, I sort of give a task that you can do, and the task for this particular session is go back to your research question. Even if it's part of your dissertation, or even if it's part of your research today, go back to your research question, or create a question from your practice, and then check out what is the design that you will use or that you must use to get the answer for it. Now, as I said, theoretical learning, just listening, does not translate into practice. You have to apply this. You have to put this into practice. It's the only way to start getting these concepts. Most important aspect of it, make sure your question is single. Make sure your question is sharp, focused, for you to be able to get the appropriate design. If your question is not simple, not sharp, not focused, you won't get good design.
Skill is incredible, and actually it was a highly productive talk. And
One question.
you please accept our okay.
You said one patient number of findings for case series. That I couldn't understand.
Can you repeat that?
One patient for case series, you put one patient with number of findings. That's why I couldn't follow that sentence. Case series.
Case series is a series of patients with new findings.
Oh, now you
With new findings.
okay. Because it is
Series of patients. One patient, new finding, case report.
okay,
Series of patients, new finding, case series.
okay, sure. Okay.
Any other questions?
No.
So, sir, you please accept the sincerest thanks for the great presentation um, that you have done and the lecture that you have delivered. Thank
Anjali,
you, sir.
sorry, Anjali Dubai has asked a question: if the study is retrospective and prospective both, you can't uh, you can't really do a retrospective and prospective study at the same time. What
Sir, what about the
sometimes
ambispective study? Can you
what
tell
about?
like that is there, no? Ambispective,
Well,
retrospective as well as
that's what I'm coming to. So
prospective.
what
Yeah,
happens in some instances is that when we are when we have a wealth of retrospective data, we start from a retrospective period and then we continue prospective.
yeah, yeah,
So
yeah.
that is
That is it.
possible. That's coming as part of the newer designs that are possible. Now you can do the same thing with a case control design. The conventional attitude towards a case control design is that outcome has occurred and you go back into a case record. So it's retrospective and you're looking at it. You can now define the case and then go prospectively. We can say that, okay, this is my definition of the case. And then I'm starting from now and I'm going to pick my cases. And when I pick my cases, I will pick my controls also at the same time. So I need not go retrospectively. I can go prospectively. And one reason why this is coming in is because the way we are diagnosing is changing very fast. And the classification and criteria used for diagnosis is also changing very fast. So if you want to go retrospective, let's say even something like hypertension, the definitions used 5 years back differ from the definitions used 1 year back. The methods of assessment differ. So we are not able to go back in records for so much time. Earlier, it was not a problem. There was no internet, there was no faster innovations. We could go back 5 years, we could go back 6 years, we could go back 10 years. But now it's not like that. We are getting a lot of biochemical markers coming in, we are getting a lot of newer techniques coming in. Something like preeclampsia, the definition changes. Fetal growth restriction definition changes, immediately changes. So then going back retrospectively becomes a problem. So what we then tend to do is that we take a shorter period of the retrospective one where we get good data and then we can move prospective. Those are part of the newer adaptations that are coming because the clinical scenario is changing around it.
Okay, sir. One more question is there, but I think this not reliable, no, not related to this topic. So how can we calculate the
The sample
sample
size.
size? I think
We'll be
that will
doing that in
be
a
dealt with.
we'll be doing that in a separate session. We have a
Yeah.
session planned for
Okay.
that where we are looking at
Okay. Okay.
how to calculate the sample size.
Okay.
Anjali is
And
asking if we are applying tumor markers on our previous histological samples. If you have a way to do that and you have a way to do that reliably, that can be done. We can look at a study that is doing that and then we can report on that. But again, it would be more in the realm of why are you doing it. It can be in the realm of a cross-sectional study where you're trying to say that I want to know if I apply this particular tumor markers now, does the magnitude of the condition or my pickup of the condition or diagnosis change. It can be in the realm of that. Or you can say that applying this on the previous samples and comparing with the previous method that I used, you can look at the diagnostic effectiveness. So again, it can go in the realm of a cross-sectional study design.
sir, one more question that is this presentation can be seen in uh,
The
this
presentation
can
will be
seen again.
available in
That's it.
the presentation will be available in Netflix. It takes about maybe a week or so. 3 to 4 days is the usual turnaround time, but depending on the number of videos that they have to manage and put, it takes about a week or so. And then in the Kerala State IRIA Club, you will find a replay of this video. So you just have to join that particular Kerala State IRIA Club on Netflix, and you can get the replay of all the sessions. That doesn't mean you say that I will get a replay, so I won't attend future sessions. Then we will cut off the replay.
Okay.
Okay, sir. I think that's the end of the questions.
Yeah.
So we may wind up. Huh? You please
Yeah. Yeah.
accept the sincerest thanks, sir, for the
Yeah.
greatest presentation effortlessly delivered. That's an
Yeah.
important thing. Okay. Thank you, sir.
Thank you, sir.
Yeah. I also thank the Dr. Joshi and the Mediflix team who are with us for the 1 hour session. I thank you so much. I thank our secretary, Dr. Rijo Matthew, with whose help we have brought this dissertation as a series of lectures. So thank you so much. Thank you, everybody. Thank you. And thank you, the residents who are listening. Over to you, Tanvi. Tanvi, are you online? I think we can end the session.
Oh, yes.
Okay. Thanks. Good night.
She's not available. I think we can go because she's not come online. Tanvi, are you online?
No, ma'am. I am here. I am here. Jyotil.
Yeah, Jyotir, can you end the session?
Sure. I am just ending it in 30 seconds.
Okay.
Thanks a
Okay.
lot. Thank you for having the session, ma'am.
Okay.
Yes.
Bye. Yeah.
Bye bye.